My agenda today, it's actually pretty simple. I want to share a few thoughts about value, and I know that's a word that we hear all the time, but I want to put it in a little different context. I want to talk about a long view about value, and in quite frankly, in some ways that we're not supposed to talk about. I want to talk about it from an industry perspective of what we're doing now and the fact that what we're doing now isn't really working. But let's start with the fact that we're just so busy. One of my observations as I go around the country and visit with our members, it's just striking that we're very busy. In fact, I say internally, one of our biggest competitors right now is time, and that people are busier than ever. And in that context, we have to think clearly and carefully, I should say, about what we're working on. And we're busy trying to do the things that we know how to do. But some of those things, quite honestly, are things that are just not working. We know how to do them well, but they're just not working. And you might say, well, why do you say that? Well, healthcare inflation is creeping up again. And all the projections are that it's going to continue that creep up and approach 20% of our GDP in just a few short years. And it's just unsustainable. Now, I would say, just so that it doesn't sound too preachy, at HFMA, we see some of the same things. We practice what we preach. So we're doing some things differently. I mentioned some earlier, but here at A&I, we're doing some things that are new. We have an A&I Executive Destination Lounge and a solution room. We have the Collaboration Hub. We've reinvented a version of our Volunteer Leadership Appreciation Dinner, again, to do things differently. Our commitment to do things differently goes beyond A&I. It relates to some of the other things that we're doing in our day-to-day activities. We're welcoming physicians and clinicians and health plans into our association like never before. Interestingly, we've been recognized for such just recently. We received from AONE, the American Organization of Nurse Executives, their Industry Partner Award. I mean, who would have thought just a few years ago that the Nurse Association would have picked a bunch of finance folks for their top industry award? So that's just one small example of us reaching out and doing things differently. Closer to home, we're doing things differently, such as our enterprise solutions model. And if you haven't heard about that, and this is not an advertisement, but it's a way for organizations to become members of HFMA. We've always been an individual membership organization until just a few weeks ago when we had our first enterprise solution client, so to speak. We don't even use that term very often in this association. But Trinity Health signed on as the first enterprise solution customer. It enables many more people within their organization to become members of HFMA, going way beyond the finance circles, but clinicians and folks that are outside of finance in other management roles to become members. So again, that's another way we're doing it. Don't get worried. We're not going to abandon the individual membership model, but it's just another way to add value to organizations and to individuals that go way beyond just another value-added option. So that's just a small snippet of things that we're doing differently within HFMA. Trust me, we're talking about things that will look significantly different over the next year and 2 and 3, as we will continue to change with our industry and change with the way that our society works. But back to the industry. Our industry's long-standing challenges are really identified in IHI's triple aim. If you think about that triple aim captures the essence of population health, and patient experience, and the per capita cost of healthcare. And we need to improve upon those things. Many of those things that as I talk to finance folks, they say, well, in real life, we have a hard time applying the triple aim. In fact, our organization's goals that apply to me or my individual SMART objectives, for example, might be much different than what's captured in the triple aim. So here's the part that might feel like a stretch, but just hang with me for a minute on this. Committing to the triple aim goals is your best chance for your organization's long-term success and for surviving in the long run. In the short term, we know how to succeed. We know what that means. That means for a hospital or a provider, that often means maximizing our fee-for-service revenues. For a health plan, that means minimizing medical claim costs, sometimes through rejections and other things that pit our organizations against each other. And we know that those things work in the short haul. But in the long term, payment for value will be the issue that will take center stage. The fee-for-service system we know is unsustainable. Healthcare expenditures, as I mentioned earlier, continue to grow. They expect 19.9% of GDP by the year 2025. We can't continue to live in denial about this going forward. That kind of spending, it will squeeze if it hasn't already, and I could make an argument that it's already begun to squeeze other parts of our governmental spending, both at a local, state, and national level. It's squeezing out some investments that we need to make in our society, and the more that becomes felt, the more the pressure is going to be turned on. So we can't continue to live in this denial, and it reminds me of a story that a friend of mine used to use a lot. It's a metaphorical story, but it's like a fisherman. And he's out fishing, and he sees out in the distance there's storm clouds coming. Like that storm came through last night, right? But the fisherman is seeing the storm clouds coming, but he's catching fish. And as that storm cloud gets closer and closer, he just can't bring himself to go in. He knows that he should, but he just can't bring himself to go in because the fish are biting. Well, those storm clouds are value-based payment. And the fish biting is fee-for-service. It's a very similar analogy and something that, again, we need to think through. So when you're ready to focus on that long-term perspective, ready to focus on that, I bring you back to the triple aim, and that's improving that population health, the per capita cost of health care, and improving the patient experience. Those are the kinds of things that we need to focus on. So what I wanted to talk about today are three issues within that get undervalued. They really don't get talked enough about, and I wanted to raise to the level of awareness today. It's a way to help achieve the triple aim, and it really focuses on things like chronic conditions. Chronic conditions like hypertension, high cholesterol, diabetes, arthritis, asthma. You know, it just makes sense that if we were to focus on those things, that it would help us achieve the triple aim, but you don't have to rely on your intuition for that. 86 cents of every dollar spent on health care in this country goes toward treating people with a chronic condition. 86 cents. And you should be familiar, if you're not, with the 550 rule. Anybody that works around a health plan would know that, generally speaking, this is all about the same, no matter who you talk to, wherever you go, 5% of their covered lives generate about 50% of their medical claim costs. Speaking of chronic conditions, spending is almost two and a half times. Person with a chronic condition, we spend almost 2.5 times versus someone without a chronic condition. Bring that up to 3 chronic conditions, we spend 6 times more on those patients than people without chronic conditions. You know the story, increased utilization, like number of ED visits, admissions, on and on and on. Things that are avoidable happen with chronic conditions that are not managed well. And the reality is you can't improve population health and reduce the per capita cost of health care without managing chronic conditions. But it's interesting, hospital executives, we rarely talk about the per capita cost, the total cost of care. It's not in our wheelhouse. It's not something that we normally do. Why is that? Well, chronic conditions are most often managed in physician offices or, quite frankly, at home. That's even better yet. Hospitals treat the complications of chronic conditions. We do that well. Again, more examples: lower limb amputations, kidney failure, heart attacks. You can go on and on. We do a nice job of treating that, and we take care of those folks with huge hearts and compassion. But from a perspective of adding to the total cost of care, it's something that's part of this unsustainable cost structure. And yet it's not in our comfort zone. It's a low-tech, high-touch process, quite frankly, and it's not one that we're necessarily geared up to do. The return on investment for management of chronic conditions is not as clear as it is other steps like raising rates or denying claims. Those are much more tangible ROI and yet don't add to the triple aim. All of these things are out of our comfort zone, but I want to take you back to the long-term perspective. The drivers of cost that we don't talk, here's another one that fits into this. Another driver of cost that we don't talk enough about: mental illness and addiction. So this past year, the first ever report by the Surgeon General under the title of Facing Addiction. Now, full disclosure, I'm on the board of another not-for-profit organization by the name of Facing Addiction. And let me just tell you, there is no coincidence that the Surgeon General report used Facing Addiction in their title. There was a lot of collaboration between that organization and the Surgeon General. And that report came out in this past year, highlighting some very important things about addiction. But in that role on the board of Facing Addiction and in my interests, I hear a lot of stories. And we all hear a lot of stories. Just last week, I heard from a friend of mine who just lost his 27-year-old daughter to addiction. 27 years old. And those stories are crushing. But here's the deal. These issues are more than just sad. And here's the part that we don't talk enough about in this country, and the report does. There are financial implications to this addiction environment. And we're starting to talk about it from some respects, but the reality is we do a lousy job of recognizing and addressing substance abuse disorders in our mainstream healthcare settings. You pick any of the three: health plans, the physician or clinical area, or the hospitals. Really, quite honestly, nobody's doing a very good job of identifying and addressing substance abuse disorders. Secondly, having a substance abuse disorder, and here's the connection: it doubles the odds that a person will develop a chronic condition. And we've already demonstrated that's incredibly costly. And those chronic conditions can be anything from arthritis, chronic pain, heart disease, stroke, hypertension, diabetes, asthma. All of those things can be either triggered by or enhanced by, not exclusively, but in part by addictions. And thirdly, the number of people living with and dying from mental illness and addiction is growing rapidly. Now, we hear a lot about this today in terms of heroin and opioid, the opioid crisis. And there's some really compelling data along those lines. One of those pieces of data, 259 million prescriptions were written in 2012 in this country. That's more than enough to give every adult American their own pill, their own bottle of pills. 259 million. And that was in 2012. Fast forward to today. So we hear a lot about that, and that's become kind of the sexy issue to talk about opioid. The politicians have jumped on that, and again, rightfully so. But here's the issue that relates to our healthcare system that we're not talking about. It's not the only issue. The health consequences and the healthcare costs associated with alcohol abuse were and are significant long before the opioid crisis, quote unquote, occurs, before the opioid issue emerged onto the scene. The graph that you do see, shows a dramatic increase in mortality by poisoning, suicide, chronic liver disease, and cirrhosis. All of those conditions can be linked to both mental health issues and alcohol abuse. All of that was addressed in the Surgeon General's report. And they talked about the fact that one of the things that we need to do in terms of the treatment is catch it early. Yet how many people have addiction treatment on their radar screens in terms of managing the total cost of care? How many value-based payment experiments incorporate substance abuse and mental health components into the mix? There are very few. Instead, we're paying attention back to what we started with. We're paying attention to what we know how to do, what we're comfortable with in the acute care sector. Consider the CMS pilot on joint replacement. If you're one of those 800 or so hospitals that are participating in that project, I know, and you know, it's an incredible amount of work. Because it's hard to do bundled payments, and it's hard to bring the parties together. And again, I've sat at those tables, and I know what it's like to look at that data and bring hospitals and physicians and health plan together to look at data differently. But if you think about that, and we ran the math here, you know, you think about pilots are designed to be able to run some data, and then if it makes sense, to extrapolate that to the rest of the industry. So what's the ROI? We ran this math. If the pilot project results of this CJR could be replicated across all joint replacements nationwide, Medicare would save about $400 million. So that might sound like a lot, but that's not. If you think about it, put that into context. $400 million represents 0.01% of the total healthcare spend. That's the equivalent, about the equivalent of the annual revenue of one 200-bed hospital. And yet, and again, I know that surgery is an expensive thing, and there's probably folks in the health plan world that's sitting out there saying, yeah, but joint replacement surgery is expensive. My argument is all that effort going toward joint replacement bundles and all those kinds of things, if it adds up to 0.01% in healthcare spending when we're busy, is that the best use of our scarce resources? And what could we save if we took that same energy and focused it on chronic conditions? Consider just one example for a second. If we had a 13% reduction in the number of people with uncontrolled hypertension, we would save the healthcare system more than $25 billion a year. And back to the triple aim, and improve many lives at the same time. Again, remember the 550 rule. My question for ourselves in this industry is, are we working on the right things? And the data would suggest that we're not. The last issue I'd like to talk about today is end-of-life care. Remember, I said I was going to bring up some topics that nobody wants to talk about. The care that people receive near the end of their lives often just, frankly, does not reflect their values as individuals, their goals, what they would like, their preferences. We know from various studies that 2/3 of Medicare beneficiaries, well, first of all, we know from studies that most people say they would prefer to die at home. The 2/3 comes from 2/3 of Medicare beneficiaries die elsewhere, not in their home, even though that's where they would like to die. Part of the problem is that we don't talk to patients often enough about those kinds of end-of-life decisions. And even when we do, and when we get those advance directives, oftentimes they're not located or they're not clear. Somehow it just doesn't work. The system doesn't work. About 25% of traditional Medicare spending is spent in the last year of life. This track record is not encouraging. Now, there are places that do it well. Gunderson comes to mind in Wisconsin, La Crosse, Wisconsin. Some of you probably heard them speak about the fact that it's a community effort to have advanced directives well spelled out and in place and adhered to. And it's made a huge difference in that community in terms of end-of-life decisions. Now, end-of-life decisions are not, let me be crystal clear with this, they are not and must not be driven by financial considerations. It's about doing the right thing, by identifying people's choices and honoring them. And oftentimes what that does is prevents the use of expensive resources that patients don't value or benefit from at the end of life. In other words, having honest end-of-life conversations to create the right environment for someone in those final days of weeks is the right thing for patients and their families. Now, people say to me, you can't talk about this. You can't talk about the financial implications of this issue. And I disagree. We should not be afraid to talk about these things. We shouldn't be afraid to talk about chronic conditions. We shouldn't be afraid to talk about end of life. It's what people want. We talk about patient financial communications and having conversations with people about, how do we help them get through the financial side of our industry. Honestly, the same thing applies. We talk about having clinical and financial worlds come together. There's no better way or no better place for that to happen than around these issues that we're talking about today. But oftentimes they feel like the third rail. I'm just dumb enough to bring it up to you today in front of all of you. So I started out today talking about the importance of taking the long view. And I would end by this. Many of you are familiar with this quote by Bill Gates. When he says, we always overestimate the change that will occur in the next 2 years, which is so true, and underestimate the change that will occur in the next 10. And the issue is don't let yourself be lulled into inaction. Remember the fishing story I told you a few minutes ago. It's interesting. It's been 7 years since Congress first authorized the hospital value-based purchasing program. It's been 7 years. And since then, there's been a ton of work that's been done. And there's been lots of experimentation. And the reality is that value-based payment system is coming. It is not in a negative sense, but they're like the black clouds of that storm that are coming. We have to start directing our attention to the things that can significantly improve value, that chronic illness, mental illness, and substance abuse, and improving end-of-life care if we're going to achieve the triple aim. It sounds daunting, doesn't it? Or even outside of the scope of what we can think that we can do. But it reminds me of a quote, and I've said this on stage many times. It's a quote, and quite honestly, it's been inspirational to me for many years in my journey from a small town in Michigan to the stage today. And that quote, quite honestly, is still on my computer monitor at work. It's yellowed and tattered. It's quite old. I think it's from the 1990s. And that quote is Eleanor Roosevelt saying, "You must do the thing you think you cannot do." And that's what we're up against as an industry. We must do the thing that we think we cannot do. I think you're up to it. I think we're up to it. I've seen the volunteers in this organization as I go around the country. I know what we're up against. I hope that this conversation and that quote will inspire all of you to tackle today's healthcare challenges with a renewed spirit and energy and determination. It's because we have to do it. And I know, I really do know, and in some respects, even coming into this speech, I felt like I might be preaching to the choir. But we have to take that message out here because I know that together we can accomplish those great things. So thank you so much, and thank you for being here at ANI.